Hello, everyone. As people start to come back in, we'll get started with the afternoon portion of our conference. Our next speaker is Dr. Priya Mitra, and she'll be talking to us about gynecologic brachytherapy. Thank you.
All right, good afternoon. My name is Priya Mitra. Thank you for joining us, and thank you for the invitation to speak here today. No disclosures. Just a little bit of background. I'm a radiation oncologist at University of California, Irvine, on the west coast of the United States. My specialized focus is in GYN and breast malignancies. I thought it'd be helpful to share a little bit of Oh, what's that? Thank you. Okay, thank you. So I thought it'd be helpful just to share a little bit of background about my personal training. When I was a resident, I was trained with LDR, so we were doing tandem and ovoid implants with cesium sources. Given their half-life of 30 years, my attending did not want to give them up, so we made the most of them. And we were prescribing to point A at that time. After I graduated residency, we were still doing point A, but I transitioned to using HDR as a primary modality, and then during that time, we transitioned to HRCTV, volume-based planning. After that, the main change that I made was really changing the fractionation that we were using. I initially started with 6 gray times 5, and as we became more and more volume-based, we transitioned to using 7 gray times 4 and 8 gray times 3. So just overall today, my objective is to discuss this transition of 2D to 3D. I'll share our workflow that we use and some tips I've learned along the way for those of you who are making that transition of things that might be helpful to know. And then we'll end with just the patient experience. This is a patient that I treated a couple of years ago. It's a 39-year-old female who came in with heavy vaginal bleeding and dyspareunia. On exam, found to have a very bulky 6 to 7 centimeter cervical mass with bilateral parametrial disease that was palpable, so FIGO stage 2B, biopsy positive for a moderately differentiated squamous cell carcinoma that was HPV positive. We thankfully had a PET CT at the time of diagnosis, and so you can see how much uptake there is with that, roughly a 6.5 by 6.5 centimeter mass on CT. So we treated her with definitive intent, and she received 5 weeks of concurrent chemoradiation therapy followed by brachytherapy. So just a little bit of history, our point A and point B dosing coming from the Manchester system, point A being 2 centimeters superior and lateral to the cervical os, 3 cm being more lateral to point A on either side. This is just an example of an implant that I did when I was a resident. So we had our tandem and ovoid there, and you can see on the x-ray there, the point A and point B is demarcated, and that's what we use to prescribe our dose. Now, point A prescription does have some limitations to it, as I'm sure everybody here knows who does brachytherapy. It really is dependent on the positioning of the applicator. So if you have a day where your applicator placement doesn't go as smoothly as you'd like, that can really alter that. It can lead to underdosage or overdosage, depending on the size of your target volume and the positioning of your applicators and where point A falls in relation to those. So the EMBRACE studies, I wanted to review a little bit because this has really changed dramatically how we're treating cervical cancers using volume-based planning and image guidance. So we'll go through each of these briefly. So the RetroEMBRACE study, the objective of this was to establish that image guidance use of brachytherapy in locally advanced cervical cancers would allow us to escalate dose to the HRCTV and spare the normal organs at risk. It was a retrospective study looking at over 700 patients across 12 international sites. All of these patients were treated with external beam radiation therapy with or without chemo, and they all had image-guided brachytherapy using either MRI or CT guidance. Half the patients had FIGO stage 2B, and about a quarter of the patients had even more advanced disease. So 75% roughly were locally advanced of at least stage 2B disease. Their median follow-up was about 3.5 years. So the results, image guidance was used for at least one HDR, and 80% of the patients had MRI guidance, and about 20% had CT guidance. The average HRCTV volume was approximately 37 cc's. The mean D90 HRCTV was about 87 gray. and HDR was used in about 60% of cases. What I wanted to emphasize was the numbers in the rectangle in the 5-year outcomes. The local control and pelvic control are 85 to 90%, which is pretty dramatic for these locally advanced cases. Cancer-specific survival in the 70% range, and overall survival about mid-60s. When you look at this graph on the left, it's looking at overall survival by stage, and not surprisingly, the patients with lower stage had a better overall survival. They then analyzed to figure out what are the key contributors to overall survival. And there were 3 main factors that really stood out. One was tumors that were 5 cm or greater, and those who had node-positive tumors, and those that did not get chemotherapy. All of them had a statistically significant worse outcome in this patient cohort. Another interesting finding that came after analyzing the retro-embrace study was that there was a change in the pattern of failure. Basically, the bottom line is we got better local control, but these women were failing more distantly. So there were a total of about 222 patients who had at least one failure, a total of 325 failure, and the addition of image guidance brachytherapy improved our pelvic control rate to 87% across all stages. About half of those failures happened within the first year, another 20 to 30% in the second year, and the predominant form of failure was primarily distant. Embrace 1 was a prospective study, observational, multi-center, 24 centers across Europe, Asia, and North America. And the treatment was, again, chemoradiation therapy followed by MRI-based image guidance for brachytherapy. About nearly 60% were treated with HDR, 42% with PDR, and the primary endpoints they were looking at was local control and late morbidity. They had about 1,300 plus patients in this group. Median follow-up was about 4.25 years. So a key requirement of this study was that they had to have MRI-based treatment planning with the applicator in place for at least the first treatment. The target volumes were per GHOS for HRCTV and IRCTV, and the maximum overall treatment time had to be 50 days for both the chemo-RT and the brachytherapy. So just a reference here from GHOS working group, HRCTV representing the residual macroscopic disease, wanting to reach 80 to 90 plus gray to that. IRCTV representing the initial macroscopic extent of disease, wanting to reach at least 60 gray. And this is just here for reference as well, showing you the coronal and axial images of the treatment contours. So looking at the demographics of the patient population, again, over 1,300 patients, about 80% had squamous cell, nearly 77% were stage 2B or higher, half of them had lymph nodes involved, median HRCTV about nearly 30 cc's, and the median minimal D90 was 90 gray. So the primary endpoint, 5-year local control, reached 92%, which I think is incredibly impressive. 5-year pelvic control, 87%. 5-year nodal control, 87%. 5-year overall survival, 74%. If you look at the graph on the right, you can see that this is for all stages. Their local control is all roughly between 90 and 100%. Looking at the morbidity, grade 3 and grade 4, I know this is a busy slide, but the bottom line is that the incidence of grade 3 adverse events is less than 5% in each of the categories, and it's even lower in terms of grade 4 adverse events. So overall, in conclusion, Embrace 1 showed an absolute improvement in local control or pelvic control of about 14 to 17%. And they attributed this improvement to target contouring and basically using volume-based planning, the implant technique, and just 3D treatment planning. Interestingly, a quarter of the patients had a HRCTV D90 of less than 85 gray. So that's something that they evaluated and incorporated into Embrace 2. Also, another interesting observation was that 2/3 of the nodal failures in node-positive patients, those nodal failures were in the periaortic region. And majority of those were outside of the target because they primarily received pelvic radiation therapy. And so therefore they incorporated the possibility of including prophylactic periodic radiation therapy in high-risk node-positive patients. So moving on to Embrace 2. This is just an overall schema of how they are treating patients, so roughly 5 weeks of chemo-RT with adding the brachytherapy in weeks 6 and 7 to respect the total treatment time to be less than 50 days or 7 weeks. This is just here again for reference to show you how they risk stratified patients based on their lymph node involvement and where they define their external beam fields. Here, just an example from the protocol. On the left is a patient with an MRI that's abnormal. You can see the primary cervical tumor. And then on the right is the MRI at the time of brachytherapy, where they've delineated their target volumes. And then they have a nice table in there of D90 target planning aims as well as dose constraints for the normal organs. So now I wanted to shift gears a little bit now that we have some background and talk a little bit about the workflow. So this is an overall view of how we do our workflow at our institution. So typically roughly 7 steps, and I'd like to go through each of these in pairs, and then I'll explain how we've evolved our program over the years. So we usually get an MRI at the time of diagnosis if possible. Now if somebody's coming to me from a facility where they haven't had an MRI at baseline, that's fine. We work with what we have, but we certainly make sure we get an MRI prior to brachytherapy for treatment planning. So some tips that have been helpful is to make sure that you work with your radiology scheduling team to make sure that these patients are a priority, especially if you're not getting the patients until towards the end of their chemo RT and they're coming to you for brachytherapy. You want to get them in for an MRI as quickly as possible. Establishing a protocol with radiology is also very helpful, making sure that you're getting the right sequences, and if you need to do an abbreviated sequence, if your radiology department doesn't have as much time, or they've got a busy schedule and they want to get patients in and out, or if a patient is claustrophobic and can't handle an MRI for an extended period of time, you may be able to just do T2 sequences, and maybe even omit contrast, especially if somebody has renal failure. We've started adding contrast gel in the vagina, which can be very helpful in visualization of the inferior extent of disease, especially if there's vaginal involvement. Getting an MRI with the applicator in place is ideal, as was mentioned in one of the EMBRACE protocols. Not necessary, but it is ideal if at all possible. If an MRI is not possible for whatever reason, another option that you can do that I learned from one of my radiology colleagues is to do a contrast-enhanced ultrasound. It's quick, it's easy, it's well tolerated, and it can really give you some helpful information. And of course, CT is there as well. Disease progression is also, I think, important to evaluate. The vast majority of patients that I've treated generally respond really well, and you see tumor regression, but I've definitely had my share of patients who have not. So by the time we get to brachytherapy, they may not be ready for brachytherapy. So oftentimes what we'll do is we'll do a clinical exam, just even in the office, where we assess the extent of disease regression before proceeding with brachytherapy. So moving on in the workflow to radiology review and the procedure itself. So again, the radiologist is really, really helpful in terms of working with them and delineating the target volume. Especially if you're new to using MRI guidance or image guidance, working with them can be very helpful. I noticed an improvement in the quality of our MRI reports once I started going to the radiology department and sitting with them and reviewing and sharing with them what would be helpful for me to know in their reports. Working with anesthesia is also very helpful. Not all institutions, mine included, we don't have the luxury of anesthesia for every case. So in the office, if we don't have anesthesia available, for the simple cases, we'll use oral Ativan and sub-Q morphine. It's not ideal, but it's better than not having anything. Conscious sedation is also an option where I've had my own nurse, our radiation oncology nurse, will push IV fentanyl and Versed to help with the patients getting through the procedure. And then if you have anesthesia, MAC usually is sufficient. Ultrasound guidance can also be very helpful. Our department purchased an ultrasound for our department, which has been incredibly valuable. Learning how to use a transabdominal ultrasound is really helpful to ensure that we minimize our risk of uterine perforations and ensure adequate placement of the applicator. If you can have an ultrasound technician come down to the department to guide you, that's also very helpful. And sometimes inflating the bladder can be very helpful as well to prop up the uterus if it's quite anteverted. Next is the CT simulation and MRI fusion. So, just some of these may sound silly, but it is important, I think, to be aware of because I've seen these mistakes happen. You want to make sure you import the correct CT data set and that it's labeled appropriately, especially if you're doing multiple fractions. It's easy for CT data sets sometimes to get mixed up, especially if somebody's covering and you have some inconsistency in that. Using MRI fusion can be very helpful, but not always. If you don't have an MRI with the applicator in place, fusion can sometimes actually work against you. So oftentimes we'll do side-by-side contouring where we have the MRI up on one screen and our CT simulation with the applicator in place on the other. If you do not have ultrasound guidance available during your procedure, I have found it sometimes helpful to do a CAT scan in our department just to check the orientation of the uterus. So if this is an example on this patient. They're different patients, but hopefully it illustrates my point. On the left is a woman who had a cervical cancer, and her entire uterus was quite distended, and it was full of blood and discharge products. After we placed the first applicator, we put a Smith sleeve in, and her uterus completely decompressed, and then it retroverted, as you can see. So that is my patient, the picture on the right. And so unfortunately on her, the Smith sleeve is there, and when I went in with the tandem, we caused the anterior uterine wall perforation. Thankfully, the patient did okay, but it was an important lesson for me to know that if somebody has a very distended uterus, you want to make sure you image, or at least consider imaging the patient before you put in your applicator, whether it's with the CT before you do the implant or with an ultrasound. Last step is treatment planning. So this is, when I was making the transition from 2D to 3D planning, we used to calculate point A and HRCTV D90, and I found that really helpful. I think it made everybody feel more comfortable as we were making that transition, that we were looking at both. I can't emphasize the importance of this spreadsheet enough. I don't know how many of you use it who are doing GYN brachytherapy, but this is extremely helpful. It's on the ABS website. I'd encourage you to keep the cells locked. It is a locked spreadsheet, and I would keep it that way because I had a team member who tried to alter that, and we were getting false numbers that didn't make sense, and went back and realized that that's what had happened. We usually add our target goals at the bottom, so it's very clear what our goals are, and we'll often populate predictions for the subsequent fractions while we're doing real-time planning for fraction 1, so we know how much room we have. Another thing that we've started doing in our department, which has been extremely valuable, is doing brachytherapy chart rounds or peer review. So it's those people who are involved with brachytherapy in our department, and we review every brachytherapy case that was done within the past week. Now, our volume allows us to do this. Usually we can cover it within half an hour. If you're in a high volume center, maybe discussing the cases that were challenging, and I feel like we've all learned from each other in terms of treatment techniques, planning techniques, and things along those lines. Fractionation, 7 gray times 4 and 8 gray times 3, I think are very, very reputable fractionation schemes to use. This is some data from a place I used to work, LA General Medical Center. So, we had a limited socioeconomic status patient population, largely stage 3 disease, and they couldn't come in for brachytherapy 5 times. That was just not possible. We were able to we were doing 8 gray times 3 every Monday we would do for 3 weeks in a row after their 5 weeks of chemo RT. We were able to achieve great target volume coverages and spare the OARs. And we only had a 1% incidence of late grade 3 plus toxicity. Now, granted, median follow-up is only 2 years. We're going to continue to follow these patients, but we're hopeful that this is something that can be done. And in speaking with some of you, I understand that a lot of other people are also doing 8 gray times 3, so that's helpful to hear. The last thing I wanted to end on was the patient experience. There's a lot of disparities in brachytherapy delivery, a lot of barriers, and sometimes it can be finances, sometimes it can be transportation, but sometimes it can also be the patient experience as well. So specifically is trauma. Trauma screening is an important part of our job, in my opinion. I think making sure that we educate our patients on what's involved with brachytherapy is important as well as making sure that the anesthesia experience is tolerable for the patients. Just a couple of slides on trauma. So this was a study looking at endometrial cancer patients receiving vaginal brachytherapy, and 84% screened positive for having had a history of trauma, which I was floored by how high that percentage was. Here's another study looking at the incidence of PTSD after brachytherapy for cervical cancer with 2 fractions using 1 applicator. If you look at the bottom, what I've outlined in red, acute stress disorder in about 30% of cases 1 week after treatment, and PTSD in 40% 3 months after treatment. So I think these numbers are real and they're not low, and I think it's important for us to be mindful of it. This is just another group looking at the female brachytherapy experience, studying PTSD, and they're getting, as you can see the numbers there, close to 30% incidence of partial or full PTSD after brachytherapy. So I hope I've been able to share a little bit about the transition from 2D to 3D and go over the workflow and the patient experience, and thank you for your attention.
time for one question for Dr. Mitra. Thank you, Dr. Mitra. Our next speaker is Dr. Anuja Jhingran, and she will be speaking on cervical cancer trials update. Thank you, Dr. Jhingran.
All right. I actually kept my talk short because I want comments and questions, okay? Seriously. So, 1999, that's the last time we actually had a positive trial. And since then, we've actually have done lots of trials. We've done 2 neoadjuvant trials followed by chemotherapy. I'm sorry, 2 neoadjuvant chemo trials followed by surgery versus chemo-RT, all negative. We've done the Outback trial. We've done the 0724 trial, looking at adjuvant chemotherapy, negative. And the Cala trial, IO plus chemo-RT followed by chemo versus chemo-RT, negative. So let's just briefly talk about the Outback adjuvant because I want to put the nail in the coffin, and I'm going to show you that slide. Outback, we all know this trial, right? Locally advanced cervix cancer, they looked at chemo-RT followed by carbotaxol versus chemo-RT. And as you can see, there was no difference in overall survival or progression-free survival, okay? So adjuvant chemotherapy did not help. And just so, because this is my lifetime trial, started in 2007, and I just presented it in ASCO, so it tells you my entire lifetime career. We looked at adjuvant chemotherapy in early stage cervical cancers, okay? Patients with positive nodes and positive perimetrium. Same thing as the Outback trial. So it was chemo-RT followed by adjuvant chemo versus chemo-RT. And as you can see, no difference in survival or progression-free survival. And it was 10 years, so this is real data. So, as I said, we're done. No more adjuvant chemotherapy for cervical cancer, okay? This is it. We cannot do these trials anymore, all right? So let's go back to, so where are we and what are we doing, okay? And we're going back to this great slide, which, again, this is a better slide than I showed you earlier. But, 1999 is the last time we did it, right? But fortunately, yay, we have 2 positive trials that we can actually finally talk about in cervix cancer. So let's talk about them. First trial, Interlace. It's a very interesting trial. It was supposed to put 700 patients, but because of the long accrual, they went to 500 patients. 250 received induction chemotherapy. And this is important because this isn't every 3 weeks chemotherapy. This is weekly carbotaxol for 6 cycles, followed within a week of chemo-RT, okay? Very different than all the other negative trials that we've had on neoadjuvant chemotherapy, where it was given every 3 weeks, okay? This is really the most important difference in this trial versus chemo-RT. And I am going to go over the patients and what patients were put on this trial in a little bit. Actually, I am right now, okay. But I'm actually going to do something else in a little bit too. But as you can see, majority of the patients came from UK. Now, she doesn't break down the demographics of what these patients are, so just because they're from the UK does not mean that they're all white, right? We just don't know, and she did not break that down. Majority of these patients are FIGO stage 2008, stage 2B. And over about 60% of these patients were node negative. And this is relevant because I'm going to come to you in a minute to tell you why it's relevant. Other things to know about this, about 70% got 5 cycles of cisplatin, but over about 90% did get 4 cycles or above. But I think, and why people are poo-pooing this trial, majority of the patients did get 3D conformal external beam. They also got point A-based brachytherapy, okay? Because it was 10 years in taking, that's why we had a change in how we treated these patients. But look at what's important, right? Median overall time, 45 days. Really important. Great therapy, right? Medium EQD2, 80 grade, not bad, right? Start from neoadjuvant to radiation, 7 days, 78% started. Within 14 days, 93. So it's actually not bad radiation therapy. This is actually really good therapy, even if it was 3D. So what are the results? Improvement in progression-free survival and overall survival at 5 years. 5 years progression-free survival, 72% versus 64. Overall survival, 80% over 72. And the thing is, because you can say, okay, bad radiation therapy, you should see increased local recurrences, right? Yeah, they were slightly higher, but it was not significantly important, 11% versus 9. Where that neoadjuvant chemotherapy made the difference was distant recurrences, 7% versus 12%. And that's where you see the difference in overall survival and progression-free survival. Okay, you guys remember this because we're going to come back to the study in a minute. But let's move on to IO, because we all believe IO is going to cure it all. We're going to put it in our waters because we're going to cure all cancers. But why does it work in cervical cancer? Cervical cancer is virally driven, right? PD-L1 is upregulated in squamous cell carcinomas, about 50 to 80%, and adenocarcinomas, 14 to 65%. And there is an increased tumor mutational burden of 5 to 6 mutations, right? So it is a cancer where immunotherapy should work. But, we have this CALA trial, and I know this is a little bit hard to read, but we are going to talk about the patient's characteristics. But in the CALA trial, patients received IO, it was durva, right, with concurrent chemo-RT, followed by more durva versus chemo-RT, and there was no difference in overall survival or progression-free survival. And in fact, the press release said, yes, we did not reach significance, okay? So, IO dead? No. So, most recent trial, Keynote A18. And this is the trial that looked at FIGO stage 2014, 1B2s to 2Bs, if they were node positive, FIGO stage 2014, stage 3 to 4s, okay? And they were randomized to Pembro plus chemoradiation followed by 2 years of Pembro versus chemo-RT. All right? What did they find? It works. So a little bit different than CALA. Pembro works. And there was improvement in both progression-free survival and overall survival. And if you look at these plots, the box plots, it's really in all stages, but the biggest advantage was seen in 3s and 4s, okay? But 100% difference in overall, there was a significant difference in overall survival and progression-free survival. The update was presented at ESMO, okay? It is 2 years only, though. Remember that. So most of these patients were still on Pembro, okay? That's important to know. So why isn't there a difference between CALA and Keynote? Why did CALA fail and Keynote win? Like I said, I'm going to try to do this so I can ask questions, right? The reason why, one, is patients. CALA had lower risk patients. They allowed patients with 1 or less positive nodes. Patients could not have periodic nodes. If you had positive periodic nodes, you were not allowed to be on the trial. The other thing is how they defined a positive node. It was 10 millimeters or greater, okay? Versus Keynote. Keynote, you could have positive periodic nodes. You had to have 2 or more positive pelvic nodes. So it's not 1, it was 2 or more positive pelvic nodes. And to define a positive node is 15 millimeters, okay? So those big differences, huge differences. And that's probably one of the reasons why Keynote A118 is positive. But the other, and why the FDA in the United States has approved Pembro for stage 3 and 4. But let's talk about major differences, what we just talked about, right? Anti-PD-1 is Pembro, anti-PD-L1 is Durva, and there definitely is a difference. So I think anti-PD-1 drugs are probably more, it works better in cervical cancer. How's that? And as I mentioned, lower risk patients in CALA versus the higher risk patients in Keynote. Similarities, maturity is similar. It's only, again, 18 months, so you guys got to remember that, right? And the number of events for first analysis. So let's go back to interlace, and let's compare interlace, right? So now we have interlace and Keynote. Which one are we going to use, and how? So what's the difference between interlace and Keynote? Key is, again, the patients. And that's the biggest difference, and we've got to remember that. The proportion of FIGO stage 3s and 4 higher in Keynote. Patients with positive nodes higher in Keynote. Only 16% of patients were node negative in Keynote. And remember, 60% were node negative in interlace, right? So the risk of patients are much lower in interlace than they are in Keynote. Okay. Like I said, I'm going to end this shorter because I do want to have comments, but real quickly, the differences. Keynote, higher risk patients, both increase in progression-free survival and overall survival. But it is a short inclusive period. Key is that what I didn't mention is all patients were treated with image-guided brachytherapy and VMAT, or majority were. There is actually patient-reported quality of life, and they were similar in both arms, and it was more of a diverse population, and we do know that. Problem with interlace is that risk factors are lower, but we do see an increase in progression-free survival and overall survival. But it's a long inclusive period. Majority of patients were treated with 3D. We don't know the diversity. We don't know the quality of life. So, what should we do? And I really want us to talk about it because I'm going to be honest, we're not doing either, okay? So let's talk about it. And I just came from a consensus conference on cervix cancer. And the answer was from that conference, it should be chemo-RT plus IO, followed by IO for at least FIGO stage 2014 stage 3s and 4s, okay? When it's not available, the standard arm should be either chemo-RT or induction chemo-RT followed by chemo-RT, right? But you guys remember the population's different. I'm going to tell you what we're going to do at MD Anderson. We're going to do chemo-RT as our standard, unless the patient has positive periodic nodes or multiple pelvic nodes, and then we will probably do Keynote, okay? But we still have a lot of unmet needs. Duration of IO, do we really need 2 years? We don't have any biomarkers. The microbiome, right? The other big one, which we were talking about, what about neoadjuvant IO before chemo-RT instead of neoadjuvant chemo? And combinations. So there's a lot. I mean, yes, we finally got 2 positive trials. And what do we believe and what should we believe? And that's really the big question. And what should we treat? And really, at the end of this concession conference, they said interlace can be used in certain situations, but they have to be, patient-related. So I'm going to open it up. Do I have time? Oh, good. See, look, I did it. Oh, look, I have 6 minutes. I really did try. So, like I said, I'm going to tell you what we are doing, right? And I know I rushed through this, but I really wanted to open this up. I'm telling you what we're going to do in MD Anderson. As of right now in MD Anderson Houston, we are doing chemo-RT. That's our standard, right? So we're going to add IO because we can, because we're in the United States. That doesn't mean that you guys can, right? Or a lot of people can't, not just Africa. I think most of the world can't add Pembro, right? It just got FDA approved, actually, for cervix cancer in Spain while I was in Spain last week. Prior to that, it wasn't. It just got approved. So we're going to use it just for positive periodic nodes and multiple positive pelvic nodes. So I would like to know, first of all, how would you treat your stage? Let's do the lower risk. So our lower risk, we're going to still keep chemo-RT, and we're not going to use interlace. What are your thoughts about your lower risk patients? What are you going to do in your centers? How about just straight chemo-RT? How many people are just going to, I mean, that light's right in my face, but how many people, just raise your hands, how many people are just going to do standard chemo-RT for their lower risk patients? Okay, how many people will use interlace or will think about using interlace in certain situations? Right. Yeah, I mean, exactly. I mean, that's a hard thing, okay? I mean, interlace is great. I mean, I have a hard time with interlace because I can't explain why giving 6 weeks of carboplatin reduces distant mets, but it could be, right? I mean, it's repopulation, and maybe it's, I don't know. Maybe it's reducing tumor burden quickly, and that's why everybody says it. I do think you have to be very careful about using interlace because they had to use GCSF. They had to use that to make sure they got, majority of the patients, and they don't have that documented, majority of their patients, they had to use that to get them through treatment. How about 3s and 4s? How many people would use interlace for 3s and 4s in their institutions now with all this data? And that's 2014 or 2008 3s and 4s, so not the new ones. How many, just raise your hands, how many would use interlace? Okay, so it's still chemo-RT, but that's interesting. That's really interesting. Okay, all right, so comments, questions, or anything I can answer? Yes? Right. Right. No, I think, no, the radiation 100% is. And just FYI, just to let you know, because the other question was the distant met issue for interlace, it wasn't periodics. So the patients did not fail. There was not an increase in periodic failures in interlace. I didn't put that on my slides, but there was, and in the paper, there's no increase in periodic failures. So that wasn't counted as a distant met. Okay, because that's right. So, yes, no, patients were tolerating Pembro with extended field with no issues, and I think radiation does play a major role in that. Yes.
I'm Dr. Ndumbalo from Tanzania. We have a problem with radiotherapy, and the waiting time is almost more than a month in some of our settings, our centers. So we are improvising using neoadjuvant chemo, and then later concurrent chemorad, even for cervical cancer. So with the weekly paclitaxel carboplatin, as you said, we have a lot of toxicity to these patients, and most of them, they end up having, not even finishing the weekly and giving them GCSF and all that. So we sometimes even improvise just giving 3 weekly. So we give the first one, the second one, probably after the third one, then we'll start chemo-RT. And that's basically most of the time we are doing. So we are not doing the interlace, and sometimes we are forced to give 3 weekly instead of weekly because of the toxicity. That's the first one. The second one I want to comment is on hypofractionation. Okay? Because of this long waiting time, we have large number of patients. Sometimes you end up having one machines. Also, we are doing some of these patients hypofractionation. So you will see we are giving, let's say, weekly carboplatin paclitaxel, and then hypofractionation. So it doesn't sit in any of those trials that you've presented, and most of the time it's not in the standard of care. Can you comment on that?
Yeah, it's because what you need to do is publish your data, right? That's the only way we're going to learn what your patients are doing. Follow your patients and publish that data. Because you're right. We do know that every 3 weeks probably doesn't work. And I think it is because of repopulation, right? And that's why all those studies have been negative on the every 3 weeks chemotherapy. Unfortunately, I do realize the burden of patients here is in Africa is so high, and so it takes that long to get patients on treatment. But there's definitely repopulation with every 3 weeks. And that's the only thing I can say why the every week worked. But every week is hard, and especially if you don't have GCSF. But my answer to you is publish your data, right? Follow your patients and let's see what results you have. Maybe 3 weeks is enough. We don't know that, right? Maybe we don't know.
Yeah, so we wrote a study that we are doing IRB now that will have 4 different arms. So the first arm will be the interlace and try to make sure that this patient with their own GCSF so that they've complete. The second one we want to do 3 weekly and then conventional, concurrent chemorad and then brachy. The third one, we want to do the hypo now. So hypo with the interlace, meaning that neoadjuvant 6 and then hypo try to do. And so that they see in all these arms, are they different in terms of the outcome later?
Yeah, no, I think that's a great study. We talked about it yesterday. I think it's an amazing study, and it'd be great to see how you do, and you probably will complete it in 2 years versus us taking 10 years to do something like that. But make sure you have great quality assurance for your radiation, because that's going to be very relevant. Okay? Thank you. Appreciate it.
Thanks, Dr. Jhingran, for a great discussion and a great transition into our next talk. Our next presenter is Dr. Solomon Kibudde, and he will be speaking on hypofractionated radiotherapy for cervical cancer. Thanks, Solomon.
Thanks a lot. It's a privilege to present this review of hypofractionation So as we all know, cervical cancer is a huge problem, especially in low and middle-income countries. That's the map which has been shown earlier, and that's the data based on GlobalCan 2022. And we can see that, especially in areas of Africa, there's a high burden of cervical cancer. I looked at the situation back home in Uganda, and we see cervical cancer contributing up to 19% of new cases as well as deaths from cancer in the country. We have one center with a radiotherapy access rate of about 10% of our cancer population. The Linux is just one machine per 15 million people. And we see up to 800 new cases of cervical cancer annually, of which the majority have local advanced disease, and the survival rates haven't improved over time. Some of the main challenges we face are toxicity, low survival rates, and poor compliance of only about 12% receiving treatment on time, as it should be. So we thought that hypofractionation could be a potential solution to outcomes. As we know, it increases convenience, cuts costs, and potentially improves access to care. So the motivation of this review was to conduct a prospective study, but before the study, we wanted to look at the literature and know what would be the ideal regimen for this type of study. So the first question is on comparative efficacy between hypofractionated external beam radiation and conventionally fractionated external beam radiation in treatment of local advanced cervical cancer, evaluated in terms of overall response rates as well as the survival rates. Secondly, we compared acute and late toxicity between the two regimens. So we used PRISMA guidelines. The protocol was registered. We included studies that add a mention of hypofractionated radiotherapy, either alone or in comparison with conventionally fractionated radiotherapy at figure 1B3 to 4A, published in English and full text available. Excluded reviews, case reports, letters, commentaries, and ultra-hypofractionated regimens, or where there was a palliative intention. So up to 9 databases were searched. This search was done in August last year. The keywords using MESH were really focused on cervical cancer, hypofractionated external beam radiation. So we did the process workflows as mentioned, and we used Ryan for screening of the articles. I did the screening with another colleague, and here we screened the titles and then abstracts. Whenever we had a bit of a conflict, we engaged a third reviewer and then moved to full text review. And overall, as you've heard in the previous talks, I think people are doing some form of hypofractionation within their departments, but there's little work published. In fact, overall, there were up to 10 publications available. And we had a paper published from our center in 2021, 2 papers from India, 1 paper from South Africa, 1 from Canada, the UK, India, and another paper from Nigeria in 2000. That was the overall quality assessment. Most of the papers were of moderate quality, as you see in the subsequent slides. You can notice that 5 out of 8 studies were retrospective in nature, and these tended to have a fairly larger sample size. Those which were prospective were really small studies in the range of 60, 40, 34 patients. Only 4 had an element of comparison with conventional fractionated radiotherapy. The regimens ranged from 40 up to 60, which was the hottest, and the dose per fraction was between 2.5 to 3.33 gray per fraction. And overall, the fractions were between 13 to 20. So there was a bit of saving by at least 5 to 8 fractions. Reporting in terms of concurrent chemo, about 3 of them never reported use of concurrent chemotherapy. We understand a bit of controversy about that. And 2 studies, there was no use of brachytherapy. The median age was late 40s. Performance status was good. 2 studies that reported HIV co-infection was in the range of 30.2 from a paper by Komen from Joburg, and up to 37.6 at our center in the UCI. Most patients had 3B cervical cancer. Overall, all patients were treated using 2D techniques, which is no longer in use to date. These were either APPA fields and box technique. Brachytherapy was mostly delivered by low dose rate at the time, and very few centers that used high dose rate. And even in that setting of high dose rate, the regimen was 18 gray in 2 at 9 gray per fraction. The low dose rate were 30 to 35 as delivered previously with cesium. Concurrent chemo was administered in 4, about half of the studies. The others didn't administer chemotherapy. And if you can look at the equivalent dose in 2 gray per fraction with hypofractionation in combination to brachytherapy, most of the cutoffs did not meet what would be the standard recommendations based on the EQD2. Efficacy was comparable in the studies that compared, and this was at 5-year. The data was a bit broad, was very difficult to summarize because different studies had different reporting points, but in those that compared, there was a bit of comparison in outcome. So these studies seem to indicate that hypofractionation was non-inferior in that context to conventional fractionated radiotherapy in terms of tumor control and survival rates in women with local advanced cervical cancer. The rates of acute toxicity were comparable. However, there was a higher risk of late GI and GU toxicity, and hence patients need to be carefully monitored. and followed up for longer. There are some appreciable benefits: improved access, patient adherence, treatment costs are less, and convenience to the therapy team. But overall, as mentioned before, there are few studies that have been published. It's possibly that theoretically we know that hypofractionation has higher benefits in tumors with low alpha-beta ratio, so there's little motivation to use it in cervical cancer. Most studies were retrospective, small size, and limited follow-up, and there was a wide variability in terms of their approach to radiation. So from this work, we can conclude that hypofractionation showed comparable outcomes in terms of and safety to conventional fractionation for cervical cancer. In studies where there was a higher dose per fraction, more than 3 gray, there was a tendency towards increased acute and late toxicity. However, when you looked at 14 and 16 versus 15, 25, there wasn't significant difference. Future studies are warranted, and people need to publish their work on hypofractionation. Thank you very much. I don't know if there are any questions. If there's none, thank you very much.
Any questions for Solomon or Dr. Kibudde? We have time. No? Okay. So our next speaker is Dr. Andy Beavis. He will be talking to us about computer simulation for radiotherapy training. Thank you.
So this is a little bit different from the last few talks, and I'm the only physicist this afternoon, so no pressure. And I'm the last one. Anyway, so I'd like to speak to you today about the title's up there. It looks a bit heavy. I promised it wouldn't be a commercial talk. It's going to be a talk about one of the applications we've done in the physics world for training. So as a declaration, I am a co-inventor of Vert, so I get a little bit excited about it. You're going to have to put up with that. And I am founder and owner of a company that exists to exploit this invention commercially. So, but I promised I wouldn't dwell on that too much. However, this picture, I think, really helps understand the concept. Okay? On the left, I've got a picture from the real world, and on the right, I've got a picture from the Vert world. What we've done is we've created a 3D simulation system that really simulates, simulates the accelerator, the patient, the treatment room, and so forth, and allows you to explore things in virtual reality in order to get a really better, a key understanding, a solid understanding of what's going on in the real world. So a little bit of background about the software, about the I was going to say product, but I promised it wouldn't be commercial. A little bit of background about the software, the program. So what it does is it brings a LINAC on proton gantries into the classroom. So we could bring the LINACs into this room here. So instead of saying, well, when you treat this patient, you've got to go and set them up, blah, 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 you go to the simulation and you run the simulation. We create patient models and simulate the treatments using DICOM data sets from treatment planning systems. So, and this is important because, you guys don't want to learn to do a prostate in the way we do them in the north of England because you'll do it differently. So you need to be able to run your own simulation from the treatment planning system. And so you can look at the treatment that you're going to use. The system has embedded beam models. That's probably more exciting for the physicists. We have photons, electrons, and proton beam models in there. So you can deliver the treatments. You can set the patient up. You can deliver the dose. You can see where the dose goes. And where I start to get really excited is you can also set up errors. Now, this is where we really learn in life, is from the experience of having made mistakes. So we've put a lot of effort into the system to be able to do that. Just like a pilot learns when they're flying a plane. They don't learn with 300 passengers in the back. They learn in a classroom. They learn to take off, then they learn to land. Then they learn to land with one undercarriage out. Similar kind of process. For the physics module, which is the thing I'm going to concentrate on today, we've got quality control equipment in there. We've got calibration and stuff, commissioning equipment. I'm going to talk about that. But there's much, much more in Vert than I've given it credit for here. Oh, and sorry, just in case I because I didn't say it. VERT stands for the Virtual Environment for Radiotherapy Training. Radiotherapy, because I'm English, okay, or radiation therapy if you don't like that. So it's not a brand new thing. We've been providing this for about 17 years, and it's used in 38 countries across the world, so it's a very, very mature training product or training system. What I'm talking about today is slightly newer than that, but the core of the system is very well matured. So there's a couple of my holiday snaps up here. The one on my far left, your far right, is MD Anderson, because there's lots of people here from MD Anderson, so I thought I'd leave that one in today. I messed up. I should have put Grotesco in. I'm sorry. But that's just me being stupid. So the bottom half of the slide is important. So it's used to teach basic concepts. It's used to help people practice the delivery of treatments like a flight simulator. You can use it to understand treatment plans. So here I've got a pancreas patient set up perfectly. We've got the DVH at the bottom. I'm sure you can't see the details of that. But then we can simulate what would happen if we had a setup error. And you'd see the difference in the DVH, and you see the beams missing the tumour. You see cold spots on the tumour. So it brings it to life. So instead of saying, we must be accurate when we deliver the radiotherapy, blah, 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 blah. You could say, well, if you were 5 mils out, or in this case, 17 mils out, that would be the effect you would see. So VERT on demand is an extension to our VERT offering, if you like, or our VERT system we've designed. And we learned this in COVID. You know, everybody wanted to learn from home, et cetera, et cetera. It's changed the way the world learns things. So we've built a learning management system so you can access the software from the cloud, and I think in the context of being here today, you know, this is important because it means you can use it for distance learning. You don't have to bring everybody into a center. It can change the way you teach. So a couple of slides just to explain the concept. So the top one is the students, the log-on screen the student would see. So I'll put my account details in there, then I'll see the next screen. This is a multidisciplinary one. So this is got a these two in the middle are workbooks. So there's an IGRT workbook. You go into there, and under there's a series of exercises that you can do. So these are set up by the course administrators, and then the students have to work through them, or the people who are training. So this is my physics one, if you like, and the one I'm going to lead on the rest of the discussion from. So I sign in here, and I see an exercise of IAEA protocols I've got to work through. On there, it's got some deadlines. It tracks the progress, so the course administrator can track how each student's coming along and move on from there. So I just wanted to point out, so if I go into the IAEA protocols, then there's a TRS 398 exercise for me to do. I hit that launch button, and what that does is it fires up the software. So then it creates a session over the cloud, wherever you are, with whichever device you've got, running the VERT system, so you don't need any special equipment to run it. So TRS 398, so this is the protocol that we physicists use to calibrate the ion chambers and the LINACs. Okay, so it's very important that we work through and understand this. So we've implemented a module or a training exercise, if you like, but software as well as an exercise in VERT to lead you through what I called an end-to-end simulation of that process. So what does that mean, Andy? Well, when we work through this information that's available, when you press that launch button, you'll get some information. So the transparent slide is a set of instructions which tell you how to work through the software and what to do. And the panel at the top is where we would record answers. So I don't know what you're like when you do your mandatory training in the hospital or the university, but I skip through everything, go to the quiz at the end, and then use Google, right? So knowing that people do that, we've built this so that you have to interact with the software to get some of the answers back. So you have to go through the exercise, and so we sort of force you to learn things. So this, I think I've already said this, haven't I? This is where we record the measurements, so I'll move on from there. On this slide, so this is a blow-up of that top window, and what I want to really emphasize here is that the system is more than just, say, an illustrative process where you run through things and you'll see some numbers come up. We actually calculate the readings that you would see or the physicists would get when they do these measurements. So why do I emphasize that so much? So if you set the equipment up incorrectly in the simulation, you'll get an answer which is correct for that incorrect setup. Does that make sense? So if you don't do it properly, the answers you get will reflect that. So when you work through it, you won't get the right answers. So we've put a lot of effort into the design of this to make sure that it really is a useful teaching exercise. All right, so this is one of the other IAEA protocols, so the so-called TRS 483. And if you're not interested in small field dosimetry, it's probably very boring. But again, I just want to use this to illustrate the process. So don't worry, I'm not going to try and convert you all to being a small field dosimetrist, especially the non-physicists. You won't thank me for it. But so what is this all about? Well, this is the first page, if you like, that you would see, that you'd work through, and it tells you what you're going to do in the exercise, what you're expected to get out of the exercise, the sort of things you should pay attention to. And the thing about small field dosimetry is it's not the same as large field dosimetry. There are a lot of nuances to it that a lot of people don't really understand. Okay? So this is the interactive screen where I would make some measurements in the software, and then I would type them into this worksheet, okay? And as we go through the worksheets, we save them all. And then those, when you're using this off of the server, all that information gets sent back to the server so the course administrators can then assess how the students work through the exercise. So in this one, in case you want to know, this is where we would work through the ratio of the 10 by 10 outputs to the 4 by 4 outputs, for those that it means something to. Okay, but the key thing here is that you're encouraged to do 3 different ion chambers because it's important that you do a number of these. And then the next step of the process is you measure then the small field against the 4 by 4, and then you use those 2 ratios to do the calibration, okay? But again, the important point here is this page is encouraging you to work through making a half by half field measurement and a 2 by 2 field measurement, and use a bunch of different detectors so that you see there's a range of answers. So we're sort of forcing people to work through the fact that if you use a different detector, you may see a different answer. Therefore, it's important to consider that when you're doing your calibration. Okay, so it's to try and encourage people to really understand what the protocol's telling you. Okay, and this may be important to some people because they may only have one detector available in their clinic. So, you know, if you only take one, you believe that that's the answer. So we work through this to try and expand people's thorough understanding, if you like. So the next page is basically reflecting on what you've done, what you should be thinking about, having seen some of these answers or having seen some of these results. And then there's another page here where you could, as a user, as a student, you could type in some points that you want to discuss with the course supervisor or the course administrator, things you want to remember, and save it. And then the last page, we submit. This goes back to the server, and then you can print off a report of the exercise you've done. So in some of the projects that we're working on at the moment, like with national training schemes, you may submit that as part of your evidence to the professional body to say you've done that exercise. Okay, so that's the background of what we've done. Here's a little bit of, hopefully, interesting stuff about how we've used it. So we've started to use those 2 simulations that we talked about, I've just talked about from the IAEA protocols, in training courses at the National Physical Laboratory in London. And the thing that we really explored around was not just trying to teach people, well, you do this, 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 because that's very boring. But what we want to do is understand, what do the uncertainties mean? You know, so if the pressure fluctuates by 20 millibars, what does that mean to your answer? And the beauty of simulation is you can play through all these scenarios and see the answers and see the results, if you like, and get the more thorough understanding. So if you like, and the interesting thing is that these courses were all deemed as practical courses, but we've now adopted this virtual practical within the practical course. So computer simulation is really coming of age, I think. So we've used it on an Estro practical dosimetry audit course. We've used it on the NPL's own practical course on reference dosimetry. Both of those were 2023. We added in the new TRS 483, that was the small field stuff, added that in this year. And we're just starting to work on the next year's course where we're going to use the cloud-based solution as part of a pre-course learning that every participant's expected to do in order to make sure that they work through some pre-course material so that, again, when they come to the course, they've already got a platform understanding of what they're going to learn so that they will pick up more information as they go through the course. Okay? It's not that we don't trust people, it's just that we know, the old teaching maximum of tell them what you're going to tell them. Tell them what you tell them what you've just told them, it works. People get a lot more out of it when you do that. And we're also in discussions at the moment with about a 2025 Estro audit course. So again, for the physicists, this will mean something. These are different detectors you can use for small fields. So, in our system, you can choose any of those detectors. The one top left is actually a photograph. That's a pharma chamber. But that's just there to show you how good our simulation of the pharma chamber on the top right is. The others are all small field dosimeters, and I'm going to come back to their use in a second. So this is one of the graphs that you can produce when you've gone through the simulation, you've made the measurements. So again, I don't want to labor this too much, but the green and the blue are the correct type of detectors to use. The red is a pharma chamber, the larger chamber that we use for larger fields. And that graph just shows you exactly why you should never, ever use a pharma chamber for small field dosimetry, because you will make over 100% error. Okay? And there have been at least 2 reported deaths because of this, because people miscalibrated their machines that way. So this is a really key point that we like to use the simulation to help people understand this, not to say, thou must never do this, but to help them understand why they shouldn't do this. Okay, in a very, very safe way, where nobody will get harmed, of course. Similar type of things on the far right. Hope you can see these curves. One of them is the incorrect detector to use. It's really emphasized here on the left, where the red one, that shape of the profile should be the same as the other two, or very close to the other two. But it's just, again, showing you that choice of the wrong detector will give you a very, very wrong answer. So, to wrap up, I'm ahead of time. Wow. Very rarely am I. I've got another, it says 4 minutes, so I'll talk about something else to go for 10, because that's what I usually do. No, I won't, I promise. So, part of the discussion, so the remote access and what I call the guided use of the computer simulation. So the Vert system is a computer simulation of these processes that we need to go through. What I mean by guided use is that in this remotely offered system, because we realize there'll be no tutor there, there'll be no teacher there telling the person how to use the software, and we don't expect everybody to be experts in the software, so we guide people through the use of the software, through the simulation, by giving them those workbooks to use and giving the tables to fill in and answers to do. So, answers to provide, rather. So we believe that this is really going to be really useful, and it facilitates virtual practical sessions for self-study, so somebody can do practical work in their own home. They can do practical work on a linear accelerator in any university, even where there's no radiotherapy department. So it can be used for self-study or as part of an MSc or professional / national training course, and we're working with people on this at the moment. It can provide experiential learning for trainees who may be isolated and use it where travel's not ideal or restricted, or even to embrace sustainability. That's something else which is very key on a lot of people's minds at the moment. We do have projects, and Matt's involved in this, I know very strongly. We're having discussions around use in Ukraine at the moment with the horrible situation that they're in. And I've been in Kazakhstan recently working with the American government, looking at building sustainable training in countries like that. So we're keen on being a part of all of those. And back home, I'm trying to persuade the politicians that this should be used as part of our national training program, but of course, you can never be a prophet in your own back garden, right? So they just ignore me there. No, we're making some progress. I'm not being fair. So this presentation today has focused in on the use of dosimetry protocols, very strongly on dosimetry protocols, but we could have expanded that to absolutely anything. Because within Vert, there's a lot of feature-rich simulation. So we could have done the comparison of a proton plan to a photon plan for a prostate or for a gynae case or whatever. We could have done calibration of the LINAC. We could have taken it commissioning of the LINAC. We could have taken it much broader. And indeed, some of our existing projects are looking at creating a LINAC commissioning training for some of the LMICs which are getting a lot of new equipment in. So we're working with the Atomic Energy Agency on that as well. And 2D to 3D courses, conversion courses where cobalt machines have been replaced. That's the work with the American government. And so to finish off, computer simulation in the use of Vert is widely implemented for therapists, radiographer, RTT programs, depending which title you use. And it's now a key feature of the MPL training courses for physicists in the UK. We continue to develop Vert. We're not done. It's a passion of ours. It's a passion of mine. We're not done by any stretch. And each year we put new features in and we build. And one of the things we're working on at the moment is more specific physicist training, because I'm a physicist and we don't want to forget our own. And the physics module is really becoming a virtual experimental platform rather than just an illustrative or demonstrative platform. So to finish off, this is a screenshot from the release that's coming out, I believe, this week, probably before I get home. And it's one of the new features. It's something I've wanted to do for years. You remember the old Varian poster with the dissolved covers? So we now have we have a function. You can dissolve the covers away of the LINAC, see all the working parts, and we put an electron beam going down the guide, and you can look at, you see the electron bunches, and then argue as to are they going fast enough or slow enough, or no, I'm joking. We show little bunches of electrons going down through the bending magnet onto the target, produce the beam, and go forth like that. So I'd like to thank you for your attention. I hope you've enjoyed that. If it wasn't something that really floats your boat, but I hope you just enjoyed it. To Mira and the Radiating Hope team for the opportunity to present. And as ever, I'd like to thank particularly James Ward, who's my other co-inventor and partner in this venture. Thank you very much.
Thank you, Andy. So that concludes our sessions for today. Tomorrow morning, 9 a.m., there's tea and a light breakfast. Starting 9:30, we'll begin the program, and we'll come round you all up just like we have been. The guests at the Sky and the Westin, the next part of the program, your shuttles be ready for you at 6:30. But that's for the guests at the Sky and the Westin only, please. Thank you so much again. Have a wonderful evening.